Okay, how is everybody doing today? Good. I was thinking of giving this talk in Spanish. Would that be okay? Yeah, that's what I thought. Great. Okay. So let's talk about this. I'm going to start with an interesting thought or a sentence. So this is the summary in one line of a project that a few scientists embarked on in the 1970s when they tried to study healthcare delivery in England under a unified, all for free medical system and comparing it to other systems. And they found this to be true, that the availability of good medical care tends to vary inversely to the need of the population served. In other words, people that need the most care receive the less care. And they found that that was true not only in their universal system, but also in other systems across the world, especially in the US. And they found that this was more true in free market economies. And what guides this is a set of vulnerability factors that individuals and communities have specific vulnerability factors that put them in this situation. And for those of you that are more graphically oriented, if you think of being highly vulnerable and being low vulnerability, the more vulnerable you are, the higher your healthcare needs are, and at the same time, the less accessibility you have to these healthcare needs, to fulfill and to address these healthcare needs. So this is an observation, again, that was observed in England and was also observed through many other countries. So to give you an example, if you are poor, your chances are that you're going to have a lot of healthcare needs, and because you're poor, you're not going to be able to see a doctor that can help you address these healthcare needs. But poverty is not the only factor that influences your vulnerability. So there's several others. So these are some of the factors that have been studied here in the US as being factors that, when present, increase your vulnerability. So if I'm unemployed, if I'm poor, if I don't have good education, if I'm not white, if I'm not straight, if I don't speak English, if I'm old, and so forth. So I didn't come up with these. These are all been studied in different populations in the US and in the world as important vulnerability factors. So it's obvious that if a population is not being taken care of in the medical system, meaning in the day-to-day life of people, they're not going to be represented in research, right? And this is, in fact, the truth. So currently, the reality is that most of the research that physicians rely on in the community to make their diagnoses and decide on their treatments is based on a very homogeneous population. And if you look around you, you'll realize that, right? That it's mostly based on white males, and that's just the truth. And we need to do better because, especially in the US is not a homogeneous country. There's 40% constituted by ethnic minorities, and some people predict that that's going to be a higher number. And so we need to do better. We need to do better in research. We need to increase representation of everybody that constitutes this country so that we can therefore have data that we can really apply to the population that we serve. And we've known this for quite some time. So back in '93, President Clinton established this NIH Revitalization Act seeking to precisely improve representation of minorities as well as females, which were very underrepresented in research. Is that 5 minutes left? Yes, okay. And so how are we doing? Well, currently, just to give you an example, less than 2% of the more than 10,000 cancer clinical trials that are funded by a National Cancer Institute include a significant amount of minorities. And now President Obama has launched this precision medicine initiative, which seeks to include a very diverse cohort of people across the country to study what makes us different, what makes us unique, what makes us the same, and with that information, we can develop better treatments. I don't know what President Trump will do, but let's hope that that's a prediction. Not one that I support, but all right. Let's hope that's not true. Let's hope that's not true. So, and this is important because we have learned many things by including diverse samples in research. These are a few examples. We know that certain blood pressure medications work better in African Americans than they do in whites. We know that Asians are at increased risk of a very severe skin reaction if they subject themselves to a certain type of anti-epileptic drug. And we've learned this by studying diverse populations. And there are other examples in this chart. So it's very important. Sometimes we learn things that from one population that we can apply to another indirectly as well. And some people say, yes, but one of the reasons is that the minorities here are just not interested in participating in research. And people have looked into this, and it's just not fully supported. And in my experience so far, we've just begun reaching out to Latino populations as well as African American populations. And Latinos so far have been very enthusiastic and excited about participating when they understand the importance of why they should participate. But just like in clinical medicine, I showed you some risk factors, or not risk factors, but variables or factors that make you vulnerable. Interestingly, the same factors also play into why people don't participate in research, with some that are unique to the research arena, like fears of exploitation, especially when it comes to clinical trials. Some minorities feel that they may be abused or experimented on. But there's a lot of overlap in these factors, is what I'm trying to highlight here. I highlight a few here in green, which are the ones that I think are very addressable, especially the education piece. And if you think about it, education is one of those variables that has the potential of really mitigating all of these other factors. If you're highly educated and you understand, you're able to cross barriers, and you're able to do the trip, and you lose fear, and all thanks to education, correct? So that's a big, something that I'm really trying to focus on. And what better area to start than in San Francisco? So these are demographics from the census in 2010, and you can see the diversity of this area. This is the San Francisco Bay Area, not just the city of San Francisco. And I just put some statistics from 1970 so you can compare. So Latinos, Hispanics are rising for sure. African Americans significantly less compared to 1970. And Asians have significantly increased. So this is a great place to try to start and really make a significant change in this area. So what are we doing? So I think the focus has been, and I should say that this has already started years ago with a Chinese cohort in the MAC, which is growing. It has grown very strong and is very robust. Thanks to Dr. Rosen and Dr. Tsai and Marian, who I don't see around here. Where is Marian? No. But I think that the two main areas are focusing on education, so educating the community about brain health, brain literacy in general. I think there's a great potential there for even mitigating social injustice if you educate people about brain health. And dementia prevention, which is one of our more recent efforts. And the other piece is just trying to extend our clinical service to the community. So we have these main sites, community sites. They're abbreviated because otherwise they wouldn't fit, but I'll run through them. So this is the Watson Wellness Community Center. This is primarily a clinic that serves African Americans in Oakland. This is the Over 60 Wellness Center in Berkeley, which serves primarily Latinos. SFGH, San Francisco General Hospital, that serves also primarily Latinos. Mission Neighborhood Health Center, primarily Latinos. 1 minute. There's a few, we have these solid relationships with the Chinatown community, and then we also go to various community events to offer education and recruitment as well. So education, clinical service, sometimes we do both efforts in one site. Ideally, that's my goal, to do both efforts on all of the sites. From here, we can refer patients to our clinic when necessary. We can also refer patients to our research department when necessary, and our 4 main research projects. There's a communication between the clinic and the research department, meaning that some people that we see in clinic, we refer to research, and then the research doctors come and see us in clinic. So we have a very nice working flow in that sense. And from here, we refer to clinical trials, which Dr. Tsai will talk about. Sometimes they get referred from clinic too. And just to end, this is a little map of the distribution. I want to do more in San Francisco, start local and expand, but that's what we're doing so far. So thank you very much.